about also some premature and ectopic beats, some AV blocks you might see, sinus block, pre-excitation. Pre-excitation, we spent a little bit of time on that. There's only a couple that we'll talk about, but if you miss them, they could be devastating for the patient. So we'll talk about how to pick those out in the same thing with Brugada. Let's do a couple of skills checks from last time we met. Last time we met, we talked about tachyarrhythmias. So these are going to be from our tachyarrhythmias. Wind, two wind, two wind. Okay, ma'am, let's do this. I want you to look at that bottom rhythm strip, because when we get an EKG in front of us, we're not going to get overwhelmed by looking at the entire thing. We're going to look at the bottom, and we're going to determine what is the rate. Okay, and I'm going to tell you it's a fast rate. Okay, so once I tell you it's a fast rate, or you determine it's a fast rate by counting, so this is a 10-second strip, how would you determine the rate? Are you going to count the R's? Are you going to do counting? What are you going to do?
Well, I want to look at the rhythm and see it's irregular.
Yes.
So I would not do the counting method.
Right, very good. So we'd have to count all the R's, right? All right, so it's a tachycardic. Now, once you identify it's tachycardic, what's the next thing you do?
See the QRS or narrow Y.
Narrow or wide? What's your thoughts?
They are narrow.
So we've got narrow, irregular tachycardia. So everything else that we know about tachycardia, we just have to focus. Okay, what are my narrows and irregulars? What are my narrows and irregulars? We have three things, right?
Atrial fibrillation.
Yep, atrial fibrillation,
And then we have multifocal atrial tachycardia.
multifocal atrial tachycardia.
And then we have a flutter with variable.
Perfect. What do you think is going on here?
It will be MAT.
MAT. And we say that because we have 3 or more different morphology P waves. And if you were to be given a scenario, what do you all believe is going to be in that scenario? What's going to be the underlying problem for this patient? Respiratory. Something respiratory. COPD, bad pneumonia, hypoxic. Something respiratory is what's causing this. You fix that underlying respiratory issue, guess what? Their EKG goes back to not multifocal atrial tachycardia. It might be still tachycardia, but you're going to fix those multiple foci that are firing in the atria. Those are going to be calmed down. And now the SA knows and the continuer taking over for our patient responsibility. Right, so very good. Multifocal atrial tachycardia. Warner, Bradley Warner. Okay, sir, what's your thoughts? Fast, slow, wide, regular? Fast? Wide? Regular or irregular? If it's regular, what do you think it is? So what do we have? Our options. Towards odds. Think about 3 or 4 slides higher than that. And we have one that's a fast rate, and then we have one that's a super fast rate. And the flutter. What is this one? Yep. Probably V10. Because V flutter is going to be like every single dark line, which starts at 300, right? V flutter is going to be super fast. And clinically, what might be the difference between a VTAC person and a V flutter person? Responsive or unresponsive? V flutter, they're not going to be responsive. Now, in real life, might they be? Maybe, but on an exam, they won't be. okay? And in real life, I say maybe, because maybe if you're sitting there talking to them, okay, before they pass out, but in general, once they go into V flutter or V fib as well, difference between V flutter and V fib, irregularity. Okay, V fib is gonna be irregular, just chaos going on, right? Okay. This is V tack. White slash parentheses Thompson, Elizabeth. Okay, ma'am. What do you think? Do you think it's irregular or regular? Irregular, narrow or wide? Narrow, so narrow and irregular, same thing as we heard back here. So which of those three do you think it is? Atrial fibrillation, okay, atrial fibrillation. Because we can see it's irregular, we see maybe that's a P wave, but they're not really clear P waves. Now, if you look up at V1, 2, 3, and AVF, those are gonna be your best leads to see those fibrillatory waves. Okay, V1, 2, 3, and AVF. All right, ma'am, you ready? All right, so this is atrial fibrillation. On this page, underlying cardiac issues will probably be coronary artery disease, hypertension, maybe a prior MI, something like that. Ross? Okay, ma'am, what do you think about this? What do you think's going on here? And I would encourage you to look in the same leads, V1, 2, 3, AVF, and see what we have going on. If we look at this ventricular rate, doesn't seem to be fast, but if we look at the atrial rate, it does. So what is that appearance of, you think? Looks like an atrial flutter. Atrial flutter, right? Because we look at those flutter waves. Okay? And the difference between AFib and A-flutter, besides we talk about regular and irregular, is AFib, multiple foci in the atria that are going haywire. A-flutter, one foci, and that's why we have those flutter waves that look very similar, because it's coming from one foci in the atria. All right. Arnold, Jacob Arnold.
Not here.
Not here. Elizondo, Larissa. Okay, ma'am. 75-year-old, retired person, 50-pack year, smoking history, family history of CAD, diabetes, hypertension, got dyspnea, productive cough, wheezing, and that's at the EKG. What do you think is going on? Multifocal atrial tachycardia, right? So that's the history that I want you to bring in. Yeah, there's a family history of coronary disease, but we didn't say that in his history, but we did say that he has got some underlying respiratory problems, and he's had an acute respiratory exacerbation. So multifocal atrial tachycardia, we can see different morphology P waves on that bottom rhythm strip. Here you can see the V1, V2, V6 as their rhythm strips. That's okay, they all, just give us different 10-second views of the heart. But in general, we'll see those three different morphology P waves going on. And then if we have this picture, we can see that we've got multiple foci in the atria that are firing. And we've got an irregular strip at the bottom with what looks like fibrillatory waves. This would be atrial fibrillation. We're going to continue on with our deliberate approach to reading these ECGs. We already know we're going to look at the rate as the very first thing, because a very fast heart rate or a very slow heart rate might kill you faster than heart attack. So we're going to look at that rate, determine fast, slow, normal. We're going to look at that rhythm. And in that rhythm, we've got to look at all the different intervals, waves, and segments. Okay, we're still in the portion of looking at the rhythm. We have not come out of that yet. We talked about tachyarrhythmias. Today we're going to talk about bradyarrhythmias. As we look at rhythm and we look at axis, hypertrophy, infarcts, we're going to correlate to what our patient looks like in front of us, and then also if we have other old ECGs to compare it to, we're gonna do that. So we gotta remember our rate, and this says regular, irregular, but really is it fast or slow? And then under a rhythm, it should be regular, irregular. So rate is fast or slow, rhythm, regular, irregular. Look at our QRS intervals. What about our ST segments? For our QRS, we're looking down at that bottom 10, a 10-second rhythm strip. And then we're taking our eyes and we're moving up to the main ECG, and we're gonna put likes with likes. 2, 3, AVF, 1, AVL, 5, 6. Okay, we're gonna put likes with likes for our ST segments. We have ST segment elevation or ST segment depression. And we're gonna look at our P waves. Do every QRS complex have a P wave? QRS after each P wave, we have a P, then a QRS complex. What about our PR intervals? PR intervals will be important about what we talked about today. And then QT intervals as well. If someone comes in and on that ECG or on our physical exam of palpating their pulse, we have a heart rate less than 60, then that would be considered a bradycardic rate or a slow rate. Certainly it could be normal, like something we call sinus bradycardia. And we know it's sinus because we can look at lead 2 and look at AVR. Lead 2 should have an upright P and AVR should have a downgoing P. Okay, it could be something like a junctional rhythm. Remember, if for some reason that the AV node doesn't fire, then there are fail-safe mechanisms in place in the heart to start taking over that pacemaker responsibility. So junctional could be ventricular, or we could have different types of heart blocks. And now, when we talk about the heart blocks, not all those heart blocks will become will present as a bradycardic rhythm. It depends on the degree of the heart block, but it still falls under bradyarrhythmias or bradycardic rhythm. There are a lot of different things that can cause the heart rate to be slow. We have decreased automaticity, so something that is affecting the parasympathetic system, right? Conditioned athletes tend to have these really strong hearts, and so their heart rate doesn't have to be very high. So you might see people with their heart rates in the 30s. You know, a couple years ago I had my appendix out and I went in, my heart rate was 38, and I was like, yes, yay. I'm not that conditioned though, so I was like, well, probably from this darn appendicitis that is affecting my vagal tone, and I don't want to move. I'm just like, oh my God. And then the surgeon's like, well, I don't think it's your appendix. I'm like, why? He said, well, because your white count is normal. I'm like, you are kidding me. So that's when I tell people, I say, look, especially when I talk to my clinical groups, you never count on the white count. So my white count was 80, well, it was like 8, but my left shift was 90. That's the key, right? But anyway, my heart rate was like in the 30s. So what do they do if your heart rate's in the 30s? What should you do? Do an EKG and see if it's normal. How are you feeling? You doing okay? Do you feel like you're going to pass out? Do you feel lightheaded? Do you know I feel fine? Except for my belly really hurts really bad. Right? So if you have somebody that you can look at them and you get their history and they're like, I think it's probably, well, there's your mistake. You think it's probably. How about let's prove that it's probably by getting an ECG, right? So we want to make sure that even though you guys are in a field in the military where people run all the time or they're healthy, if they have a low heart rate, let's get an EKG to make sure we don't have any specific cause and it looks like it's sinus bradycardia. Inferior wall MI. An inferior wall MI can take out the right coronary artery, can affect the right coronary artery, and that right coronary artery can actually take out the SA node, and that can cause a bradycardia. Medications, the A, B, C, D medication. Certainly if someone's hypothyroid or hypothermia, they can have a problem with their pulse rate being pretty low. Hyperkalemia, stroke or intracranial mass. What about Lyme's disease? Have you guys done infectious disease? Not yet, right? Oh, that's no fun. So Lyme's disease actually can cause something called Lyme myocarditis. And Lyme myocarditis can cause these patients to be bradycardic. So you might be thinking about people up in the Northeast where Lyme's disease is more prominent. These patients can range from completely asymptomatic, especially if they're young, healthy, and this is silent bradycardia, but they can have other symptoms as well, very similar to what they can have with tachycardia. Lightheadedness, dizziness, fatigue. They can have change in mental status because if your heart rate's not beating fast enough, you don't have good perfusion of the blood, and that means you don't have good perfusion of oxygen. That's going to affect the brain. pre-syncope or syncope. The sinus bradycardia is going to be a heart rate that is less than 60, okay, but we're going to have an upright P in lead 2, a downgoing P in lead AVR. Upright in 2, downgoing, and then our rate's going to be at the bottom. So 1, 2, 3, 4, 5, 6, 7, 8. We do that 8 times.
6 times.
6, 8 times 6, and we gives us a rate of 48. So that is a bradycardic rate. This appears to be a sinus bradycardia if we look at the rest of our lead 2 and our lead AVR. We know that we have something called overdrive suppression. Okay, that SA node, if it doesn't fire for some reason, could be from an MI, could be from respiratory issues, could be from electrolyte derangements, okay, or could be the fact that we're giving patients medications, they're taking too much, or they're just having a reaction, or they have a normal side effects of that medication. So any of those things can cause suppression of that SA node. Once that SA node is suppressed, there's a specific, what's the word? I had it and I lost it. Specific order, specific pattern, specific order in which the heart is going to take over pacemaking. So we know if the SA node doesn't pace, then the atria, somewhere in the atria will pace. If that doesn't start pacing, the junctional area, and then we'll go down to the ventricle. Okay? So when this happens, we should be able to identify that change on the ECG. Okay? So the first thing we may see is a junctional. Now we know that the part of the atria should fire first. But I'm going to talk about that, I'm going to talk about that last, because if the atria, SA node didn't fire, but part of the atria, one part of the atria focus started to fire, what is our rate that we typically see? 60 to 80. So that's truly not a bradycardic rate. So we're going to talk about what that's going to look like, but we're going to talk about junctional first, because junctional, we know, is going to be a rate about 40 to 60 on average, right? There is something called accelerated junctional. It's going to be a much higher rate. I want you to focus on what the norm is, which would be a junctional rhythm. So it might be what we call a junctional escape rhythm, or it might just be when you look at that entire ECG as a junctional rhythm. When we think about an escape rhythm in general, what happens is we've got firing that is occurring normally. The SA node is firing, it's firing. For some reason it doesn't fire, and then we have this longer pause. Okay? The body recognizes, hey, wait a minute, I was supposed to get, something was supposed to fire here and didn't fire. So once that we have that longer pause, the next area that is supposed to fire takes over firing. If the atria doesn't take over, then it's going to be the junction. So for this specifically, we're going to focus on the fact that nowhere in the atria fired, and the area around the junctional or the AV node area is what took over pacemaking responsibilities. So we started with a PQRST. If we can look at R to R, looks pretty regular. But what happened was, if we go R to R, and look, we should technically have another PQRST right here. We should have depolarization of the atria and the ventricles here, but we didn't. The body recognized that and said, okay, I'm going to wait. The junction said, okay, I'm going to wait a little bit longer, wait for something to fire, and it didn't. So what happened? The junctional area took over around that AV node. And we know this is a junctional escape rhythm because we don't see P waves. Now, sometimes with a junctional, so we have a junctional, we don't see a P wave here, we don't see a P wave here, and look at the difference in our R to R. So R to R here gives us that rate of, that's 60 to 100. So 300, 150, just less than 100. Okay, so maybe 85 or so. Okay, but here, look at the delay that we have, because we know for junctional it's going to be that 40 to 60. So now we're talking about a rate of 300, 150, 175, 60, 50, a little less than 50, right? And that goes along with a junctional rhythm. This bottom one, we have a junctional rhythm going on. We don't see P waves. Occasionally, You will see a P wave, okay, but it's gonna be inverted. And the reason why is the area that's taking over pacemaking responsibilities, if it's higher up in that junctional area around the AV node, okay, then it's gonna cause retrograde depolarization of the atria. So retrograde depolarization of the atria is gonna be shown on your ECG as an inverted P wave. So junctional can come as no P wave at all or inverted P wave. And sometimes you even have P waves that occur after the QRS complex because of that retrograde inversion, or that retrograde depolarization. We have a P wave here that's occurring just before the QRS, and it's inverted here. This P wave actually is afterwards, it's within the S wave, and then we've got a P wave that's way over here. We're not gonna see anything like that on the exam. We very, very rarely see anything like that in real life either. I want you to notice though, these that have the P wave after, it's not the importance of identifying that the P wave is after, it's important that you identify there's no P wave before. Okay? There's no P wave, I don't see a P wave. Why don't I see a P? Why don't I see a P? You can hem-haw all day long and say, well, there's my P, I think that's a P. It doesn't matter. What matters is we don't have it before, we don't have it before, and here we have it before, but it's inverted. This is an example of a junctional rhythm, meaning I didn't start off with a normal sinus rhythm and then escaped into a junctional. This person, where this EKG came from, is in a complete junctional rhythm. The SA node is not firing at all. The atria are not firing at all. And how do I know that the atria didn't take over pacemaker responsibility? I don't have a P wave. I don't have a P wave. Even if I had inverted P waves, that tells me that's retrograde depolarization. So junctional is going to be no P wave and a narrow QRS with a rate of 40 to 60. Sometimes the junctional area doesn't fire as well. And the last ditch effort is going to be that ventricular area is going to fire. We're going to take over pacemaking responsibilities. Again, this could be just a ventricular rhythm, okay, or it could be a ventricular escape rhythm. Meaning we started off with a normal QRS complex. So PQRS, 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 and then for some reason, the SA node didn't fire, the atria didn't fire, the junctional area didn't fire, so now the ventricular area, the ventricles took over pacemaking responsibility. We can see that it occurs later than what it's supposed to, that QRS complex, a depolarization. So if we measure from R to R to R to R, we would think that we would have a QRS complex about right here. This is occurring later, much slower in rate, and you know it's coming from the ventricles because of the wide complex in that QRS. Why is the QRS so wide? Does anybody know? So the reason why the QRS complex is so wide is because something is infecting our normal conduction pathway. When we go SA node, AV node, down to that, something's affecting that. So instead of us using this automaticity, okay, this if we were to draw a line in how this electrical conduction normally occurs, we are now conducting and depolarizing myocyte to myocyte. Or not getting that quick depolarization like we normally would because something has knocked out the electric conduction pathway. So instead, we're still depolarizing, but cell to cell to cell to cell via those gap junctions because sodium is going from cell to cell to cell. So we know that when we look at the QRS complex, that QRS complex represents depolarization of both the right and the left ventricle, right? Well, this is kind of your indication that they are still depolarizing, but they're depolarizing at a slower rate, so it's going to be wider than our normal QRS complex. On top, we can see these wide, ugly QRS complexes. That tells you this is coming from the ventricles. And usually again, myocyte to myocyte. This is called a ventricular escape rhythm because it's occurring later than when we would think our normal QRS complex would occur. and it's ventricular because of the nature of that wide QRS. Are you gonna see P waves before it? No, because we already know that the SA node isn't firing. Because the ventricles are still firing, and ventricles, when they fire, it's a big deal, that you can cause actually retrograde depolarization of the atria as well. So sometimes you'll have P waves that are very, like this is actually a P wave down here, there's a P wave here. But again, the key for you guys is I don't have a P wave before this. Wherever that P wave is at is where it's at, but I can tell by how wide this QRS complex is that the depolarization is coming from the ventricles. This bottom one, we have that same thing. We have depolarization, wide QRS complex, wide QRS, and wide QRS. We know that that is coming from the ventricles, from myocyte to myocyte. Now these patients that have a ventricular rhythm, they're probably going to be a lot more symptomatic because of the rate of their heart. Because their heart rate is typically 20 to 40, or not having a significant amount of perfusion. So either they passed out, or they're going to feel like they're going to pass out, or dizziness, something like that. Here we have a ventricular escape rhythm. So look at our first two beats in this bottom rhythm strip. P, QRS, we have a flat T. Maybe that's the problem. Okay, but we have a P, we have a QRS. Does everybody agree that they see a P and a QRS here and a P and a QRS here? Okay, so if we follow this out, this didn't really come to fruition, and then we have these wide QRS complexes here. If we were to look at the rate, 300, 150, 175, so a little bit higher than what we think is at 20 to 40. Okay, but again, this also was an escape rhythm, but this is a wide QRS complex, and that is concerning for coming from the ventricle area. Let's go back to our atrial escape. Again, atrial escape is going to give us a little bit higher heart rate, 60 to 80. And if you just had an EKG and it was all an atrial escape rate and rhythm, okay? So I gave you an EKG, you looked at the bottom, you said, okay, that's 80, and you looked and you saw QRS complex and you saw P waves. Would you believe, do you think that you would be able to tell the difference between that and whether this is a normal sinus rhythm? You wouldn't. You wouldn't. Okay? I mean, you might, if you're really good at EKGs, you might be able to figure out that the subtlety is in the P wave and how the P wave presents. But so the reason I tell you that is don't expect to see that on your exam either. I'm not going to be like, hey, is this an atrial rate or is it a normal sign? I'm not going to give that to you because in real life you may not be able to pick that out. If you were to start off with a normal sinus, PQRST, 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 so what we have here, we can say our R to R looks pretty even. We know if we look from here to here, that doesn't look right because if we march this out, I should have a PQRS complex right here. I should have a PQRS right here, and I don't. So this beat here is occurring later than we should. So now in our mind it's like, okay, why is that occurring later and what is causing it? Where's the depolarization coming from? How you know it's an atrial depolarization is even though it's occurring later, it still has a P wave associated with it. Okay? But if you compare this P wave to these P waves, this is your indication that it's from a different foci in the atria. These P waves are more rounded. This P wave here, here, here are more pointed. So that tells you it's a different foci in the atria that's causing this depolarization to occur. This is an atrial escape rhythm. We've got that rate of 60 to 80. Normal QRS complexes with a P wave, but that P wave will look different. Again, and it's easy to compare if you have that normal sinus to start with, and then you have this atrial escape. If you have an entire EKG that looked just like this, you probably won't be able to pick it out. That is it for our escape. So just think junctional. It's going to be more narrow, either no P wave or inverted P wave. Ventricular, wide QRS complex. Okay, the rate 20 to 40 or so. Ventricular, 40 to 60. Those are going to be your biggest clues. Is look at how if it's wide, it's going to be ventricular. If it's junctional, we're going to go with narrow. Or if it's narrow, it's going to go junctional, and then that P wave. Let's go into our AV blocks. Again, not all AV blocks are going to cause a bradycardic rate, but when the experts talk about bradycardia, they put these AV blocks in there because of the tendency for them to cause lower heart rates. So we've got a first degree AV block we'll talk about. Second degree, there's two forms of second degree. We've got a Wenckebach and a Mobitz 2. So Mobitz 1 is a Wenckebach, and then we have Mobitz 2. And third degree AV block. First degree, what can cause it? Well, it could be a normal variant in people. Okay, so some folks come in, we do an EKG on, they've got a first degree AV block, could be totally normal, they're asymptomatic. It could be from thyroid problem, it could be from electrolyte. Look at their medications. Second degree, Wenckebach. We think maybe more significant underlying cardiac disease might cause that. Second degree, Mobitz 2 is more of a big deal. The Mobitz 1 we can deal with. Mobitz 2 is a big deal. Those patients often end up with a pacemaker. And third degree, cocaine. Cocaine is a big cause of third degree block. Myocardial infarction can cause it as well, and myocardial ischemia can cause third degree AV block. First degree AV block. In a first degree AV block, we're going to have our P, we're going to have our QRS, we'll have our T. The issue with first degree AV block is the PR interval. PR interval. We know a normal PR interval is, you guys remember? 3 to 5 small boxes. 3 to 5 small boxes or less than 0.12 to 0.20. So first degree AV block, that PR interval is long. It is greater than 0.20. Consistently, I've got a P QRST. My PR is 0.225. I've got a P QRST. My PR interval is 0.25. It's 0.25. Consistently, every time, every beat you look at, it looks good, except for the PR interval is always long, and it's the same. When you measure it out, it's going to measure out. Same here, same here, same here, same here. It's just longer than normal. It's just longer than normal. Again, could be a normal finding, but I would tell you for active duty especially, if this is something that you find on an ECG, okay, even if the patient's asymptomatic, it probably warrants just a quick cardiology consult. Hey, the person's asymptomatic, first degree heart block, this is the first EKG they ever had, and that way they can clear them to make sure they don't identify any underlying cardiac disease. Normally, there's no specific treatment once they've been cleared, and it's just something we document in their medical records. Prolonged PR interval, that's it. But it's the same every beat. It's consistently prolonged. It doesn't get longer and longer and longer. It's consistently prolonged. That's first degree AV block. Here is an example of first degree AV block. We've got our R wave here, okay, so we call it our QRS complex. And then this is our PR segment. It starts at the beginning of the P all the way to the R. And here we've got one big box. One big box tells us that 0.20. And then beyond that, we've got another 1.5 boxes or so. So that's greater than one big box or 5 small boxes. That in itself is a prolonged PR interval, and that is first degree AV block. Same thing here. And then we can see on this, we've got our R wave here, we've got the beginning of our P here, that full box, and then we got one more small box after that. So that is prolonged, but consistently prolonged. It's the same here. It's 6 boxes here, 6 boxes here, 6 boxes here. All right, everybody understand first degree AV block. Prolonged PR consistently greater than 5 small boxes or 0.20. This is an example on an ECG. Look down, that's at that bottom rhythm strip. That's we're going to look at our PR segment, we're going to look at our QT segment, down at that bottom rhythm strip. This is a prolonged PR. Sometimes it is so prolonged, it'll come right off the back end of that T wave. So if you happen to see on an EKG, a T wave, and there seems to be like something right next to it, guess what? That might be your PR interval. Go look next to your QRS complex. If you don't have a P wave there, your P wave way back there next to the T wave because it's so prolonged. Here it's not that prolonged, just a little prolonged, but about 6 boxes. All right, so that's first degree. Second degree AV block, Mobitz type 1, also called Winky-Bach. In Winky-Bach, what we say to help us remember is longer, longer, longer drop. I must have a Winky-Bach. And we're still referring to the PR segment. So the PR segment, when you look at the first one, it might look normal, but then you have to look at the next one. And you're like, wait, looks like it got a little longer. I'm going to measure it out. It did get a little longer. And then the next one, a little bit longer. From beat to beat to beat, that PR segment gets longer and longer and longer until there's no conduction at all and I don't have a QRS complex. Okay, so P waves here, and if you look at this PQRS, it looks pretty normal. Okay, it's less than 5 small boxes or 0.20. But then if you measure from here to here, does everybody see that PR interval here versus a PR interval here is different? This is longer. And then look what I have. I have a P, but I have no QRS. At that AV node, it blocked completely the depolarization going down to the ventricles. Completely blocked it. The body recognized it and said, whoa, wait a minute. So it kind of reset itself, and then we went back to a PQRS. But guess what happened again? This looks normal, prolonged, and then we got a P wave without a QRS. So when I tell you, when we're looking at that rhythm, you've got to make sure that QRSs are after the Ps and the Ps are before the QRS. That's the reason why. If we have an AV block, you'll have Ps without QRS complexes. Where the atria are depolarizing just fine, the issue is at the AV node area. Something is causing a block and will not allow that depolarization to get down to the ventricles. This bottom one here, we have a P, we have a QRST, we have a P, QRST, so that looks okay, but just look at your PR segment from here to here, and you'll see that this PR segment is longer, and we have a P wave without a QRS complex, so longer, longer, longer drop. And not that fact every time it's 3 times, that's just the same. It's longer, longer, longer drop. You can go longer, 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 drop, okay? Just a saying to help you remember, longer, longer, longer drop must be a Winky-Bach. So it's getting progressively longer to the point we have a P wave, no QRS, and then it'll go back to PQRS, but those PR intervals are going to consistently get longer. This is an example of a second degree AV block, Mobitz type 1, also called the Winky-Bach. Okay, so again, we're looking at our P wave, we see our P waves, yep, we're happy with that. Once we get down to the area where we're looking at the time we're looking at our PR intervals, okay, let me measure my PR interval. Just take your piece of paper and measure that first one. At the beginning of the P to the beginning of the R, move it over to the next one. If it doesn't line up, move it over to the next one. Wait a minute, this doesn't line up. It looks like it's getting longer. That's your clue. That's your indication that this is a Winky-Bach. So we've got P here, we got a PR interval here, getting longer, a little bit longer, a little bit longer, and then we've got a P without a QRS. So some of y'all might be saying, well, how do I know that's not a T? Here's your T, here's your T, and then we got a P. Here's your T, and then we have a P. T, P. Okay? So the P wave is there, we just don't have a QRS. And then the body resets itself, and we go back to the same thing. We have a prolonged PR. So that's a Winky-Bach. Longer, longer, longer drop must be a Winky-Bach. This is an example of, next we have that second degree AV block, Mobitz type 2. Mobitz type 2. So Winky-Bach is a type 1. Mobitz type 1 is a Mobitz type 2. Again, more serious. These patients definitely need to see cardiology. Oftentimes they end up with a pacemaker. Depends on what their degree of bradycardia is. But the issue we have with Mobitz type 2 is just spontaneously we start getting drop beats. So look at our PQRST. Does that look normal to everybody? That looks pretty normal, right? We've got a normal PR interval. It's not greater than 5 small boxes. Normal PR interval. but I have this. Okay, and what happens is your P waves will march out, but you're missing a T wave with that P wave, or T wave. You're missing your QRS complex with that P wave. So march out your P waves. Okay, my P wave, my H waves seem to be depolarizing just fine. Why are my QRS complexes not showing up? And they're not because we have a complete block of conduction down. So PR interval looks okay, but just spontaneously we get these dropped QRS complexes. So you can imagine, depending on how many QRS complexes are dropped in a row, will depend on the rate of this patient's heart rate and the degree of their symptom. So here we have, you can't really see this P here, but it's a P QRST, and then we have a P wave and another P wave. And again, these P waves are marching out, but we don't have a QRS complex here, we don't have a QRS complex here. P wave, QRS complex with a T, P without QRS, so no ventricular depolarization, only atrial depolarization, something at the AV node is completely blocking that depolarization. So if you have, this is 6 second, 1, 2, 3, 4. 4 R waves on a 6 second strip gives us a heart rate of 40. That's pretty low. That's pretty low. These patients are probably going to be symptomatic. And that's again why they typically will end up with a pacemaker. That's a second degree Mobitz. Yes, sir.
And was this display like rhythmicity at all to it? Like it looks like it's pretty consistent.
Not necessarily. No, not necessarily. This just happens to be, but in real life, not necessarily. You might have here, you might just have one P without a QRS, and then you might have many that are okay, and then you might have 2 without QRS. So there's no rhyme or reason on why it allows some depolarizations to go through and some not. Here is an example of Mobitz 2. So the Mobitz 2, or Mobitz type 2, okay, our ECG. So we've got a PQRS-T, and you can see we have a P wave here without a QRS complex. But our P waves, again, are marching out. They're marching out. Here we've got a P, normal PR segment, normal PR segment, normal PR segment, P wave without a QRS complex. And we got the same thing here. Okay, come over here. All right, so again, PR interval for this is normal. You just have spontaneously dropped QRS complexes, so spontaneous blockage of depolarization down to the ventricle. Third degree AV block. This is always the one that kind of messes with people's brains. In a third degree AV block, we have complete block of depolarization down to the ventricles. SA node is firing. SA node has no cares in the world because it's doing its job. Problem is the AV node is not, or something in that junction is not allowing any of these those depolarizations to go down to the ventricle. But the SA node doesn't know that, so the SA node is firing along, 60 to 100. Ventricles aren't receiving any impulse from above. So the ventricles are like, well, I guess I've got to take over pacemaker responsibility because no one else is doing it, so ventricles are firing. So we got, okay, so ventricles are doing their thing at 20 to 40. SA node is doing its thing at 60 to 100, but they're not communicating at all. There's a complete block of that depolarization that's going out. So when we measure this out, our P waves are going to seem to march along. Our QRS complexes are also going to seem to march along, but they're independent of each other. So if we have, you see this little strip right here, we've got a P wave, we've got P waves, we've got P waves here. But with each P, you don't necessarily see a QRS complex, but so people oftentimes will confuse this with Mobitz type 2. The difference is our QRS complexes line up. The QRS complexes line up. Your rate is also typically going to be different. We're talking about a ventricular rate of 20 to 40, because it's the ventricles are the only ones that they're both depolarizing, but it's going to be at that ventricular rate. So the P waves march out, The ventricular rate march out, but they're not talking to each other at all. This is an example of third degree AV block. So we've got a QRS complex here. It's small, okay, small in amplitude, QRS complex here, QRS here, 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 a little bit bigger here, here. All right. So the first thing we're going to do is we're going to look and we're going to say, okay, I've got this, and it looks pretty darn slow. It looks like a bradycardic rate by QRS complexes, right? That's what our pulse is, our QRS complex, our depolarization of the ventricle. So it looks pretty slow. Okay, now I've got to identify, do I have P waves? Well, really, I wouldn't blame you if you didn't notice there's a P wave, but you can look here and say, okay, well, that P wave looks to be okay. But I don't see specifically a P wave that's associated with this. Maybe that's it, I don't know. Okay, same thing here, I don't see it. So now I'm gonna have to start figuring out, wait, if I have something here, let me look, maybe that's a P wave. And this is not in real life even. When you see these third degree AV blocks, you're like, wait a minute, why is this so slow? What is causing this to be so slow? And if I'm going to put my bradycardia differential diagnosis, third degree AV block is going to be on there, a second degree Wenckebach is going to be on there, and a second degree Mowitz 2 is going to be on there. But on these third degrees, these patients oftentimes will have a history of like either cocaine use or an inferior MI. Okay, and it's going to cause that, it's going to knock out that AV node. So we have independent depolarization of the atria over the ventricles where our P waves are all marching out, okay, regularly, and then our QRS complexes. If you march these out, they also measure out regularly. They're not talking to each other. So you have your P's, and you're not really having missed QRS complexes here, they're just delayed because of the fact that they're not talking to each other. Yes, sir?
What about the T waves, man?
Well, you're probably not going to see a T wave if you have an EKG looking like this because something is really awry. And not to say that things are not repolarizing, but we have such chaos going on in the heart that the EKG machine is not going to be able to pick that up. Okay? So this is something severe hyperkalemia can cause this, or some significant electrolyte issue. Like I said, an MI. But sometimes when you have such a significant issue with the heart, you're not necessarily going to see some of those normal waves. Doesn't mean that repolarization isn't happening, because obviously it is, because we're getting another depolarization, but you're not going to be able to see that all the time. Sometimes it'll eke out a little bit, but like if you look up here, so you've got your QRS complex here, and what is this up here? Well, that's your T wave there. You just can't see it in lead 2. Right? So you've got a T wave up here. This is your P. That's really about the only lead that you can see a good T wave in is up in D5. This is a T wave here, T wave here. So you can see it more in your anterior, kind of your septal and anterior leads. You just can't see it down there in lead 2. So if we put this in a summary slide, first degree AV block, consistently prolonged. Yes, ma'am.
Ma'am, if the atrium and ventricle, they are not talking to each other, where does the ventricle getting the conduction from?
It's not. And that's why it's firing. If our electrical conduction system was working correctly, the ventricles wouldn't have to fire independently. But it's not getting signal from above, which is why it's so slow. So they're firing. So think of this again as a kind of a ventricular escape rhythm, where we're not getting firing from above, so the ventricles are taking over pacemaker responsibility, right? And if it was getting firing from above, our rate would be much faster, because it's going to be going with that normal SA node down to the ventricles. But because we're not getting firing from above, the ventricles are firing at their own inherent rate, that 20 to 40. So they're not talking, it's getting it by virtue of still that overdrive suppression, where it's not getting insult from impact from above, so it realizes it has to take over on its own. So first degree AV block, consistently prolonged from beat to beat, that PR segment, PR interval, not segment, PR interval. Our winky Bach, longer drops. Our PR intervals are getting longer, they're getting longer, they're getting longer, they're getting longer, and then we have a P wave with no QRS. What are you guys laughing about? Longer, no, nothing else, something else is fine.
No, I do have a question though.
Yeah.
You said that the difference between Modus 1 and Modus 2 was that the P interval gets longer and longer, correct? How is that a differential for type 3 if you can see that the P waves are consistently getting longer than Modus 2?
Ask me that, so between Mobitz 2,
Right, you said some people confuse type 3 with the Modus 2, but for Modus 2, they don't consistently get longer.
right,
Would you see a consistent PR interval between the QRS and the P wave?
on 3, on third degree Bach?
No, that's what I'm saying.
Okay, in Mobitz 2, your PR interval is the same, it's normal PR interval, okay? But you just get drop P's. In third degree AV block, you can't even really, like your PR interval is not even there. Like if you want to do a PR interval, you can see, oh, looks like that's a first degree, it's way over here, right? So I never really understand why people get them confused, but they often do. But in type 2, your PR interval is the same, and you just get drop P waves. In winky Bach, yes, it is prolonging, but you still see a very clear PR interval. Like it looks fairly normal, but it just gets longer. For third degree block, you can't even really, like, there's no way that you can look at this and say, well, that would even become close to it. Like you can say this is a PR, you can say, I guess you could say that's a really short PR interval there, right? But if you come over here, we're not just progressive, like it's significantly longer, and your P waves should be marching out in third degree, and it doesn't necessarily march out when you're talking about your winky Bach. Right, so if we come back to winky Bach, okay, we measure this out, and we are clearly missing a QRS complex after that. If you go to third degree AV block, okay, you're missing multiple QRS complexes after those PR intervals. So when I want you to think about third degree block, think about how these patients might present. Okay, they're going to present lightheaded, dizzy, syncopal episode. Okay, look at that bottom rhythm strip. In that bottom rhythm strip, look for those QRS complexes. Those QRS complexes in this is going to be really, really slow. So your rate is going to be a really slow rate. And then you'll be able to then pull back and find, so if you can see those P waves. Just march those P waves through and march this through. You're not missing QRS complexes. They're there, where when we talk about winky Bach, we're missing them. Like they're just not there. Here they're there, they're just not associated with the P waves. So if you were to measure out those QRS complexes on the winky Bach, but I'm missing one here, like I should have one here and I'm not. If you measure these out, go from this P what in the world? If you measure this out, okay, from your QRS to QRS, they're measuring out, they're just way far away from each other, but they evenly measure out, knowing that the ventricles are spontaneously depolarizing on their own. Does that make a tiny bit of sense? For you, because you know EKGs, but maybe not necessarily for others. So think about winky Bach. When you measure those QRS complexes out, you'll be like, okay, I go take my piece of paper, I put it on this R wave and the very next R wave. Move it over to the next R wave, to the next R wave, to the next. You should eventually be like, well, wait, I'm supposed to have an R wave. I don't have it. If you take your piece of paper on this and you measure this out, my paper's not long enough, but measure this out, this will align with this, will align with this. You're not missing them. The ventricles are beating on rhythm, 20 to 40. Okay, they're beating on rhythm, it's not missing any, they're just not talking to the atrium. So they're there, just like they're supposed to be in that 20 to 40 rate, okay, but we also see P waves that are not talking to the ventricles. Okay. Hopefully. So the block summary, we got a winky Bach, longer drop. We've got our Mobitz 2. notice too, PR interval is going to be normal, but we just got spontaneous drops of our QRS complex. And then third degree AV block, very low heart rate in our bottom rhythm strip. We're going to see our QRS complexes. Once you put your paper on those QRS to the first one, and then go to your next R, move it over to your next R with a QRS complex. Move it over to your next. They're going to line up. They're going to line up perfectly. Okay, but what you have in between there is a bunch of P waves because the atria is still depolarizing at 60 to 100 beats a minute. So you're going to have a whole bunch of P waves to about 4 to 5 R waves along that bottom end, or maybe 5 or 6 R waves along that bottom portion of the heart rate of 20 to 40. Now we have to talk about, whoa, wow, y'all just let me talk forever. All right, let's take a break.
Come, Sam.
That's like a place where you use it, so like use like words that takes out. Yeah. It's like it's called medical work. Yeah. The only reason it's so much of just select like like select things. It's like it's keep pasting.
Yeah, because I know you never get a hand return.
QRS will just but you gotta pay attention to this. Now this one is a bad example because QRS really works for so I would tell you that
Yeah, so it's and for sure, just make it yeah, exactly.
that's what I was talking about. Tall trees and low bushes. You see tall trees.
Oh, man.
Is that just regular bradycardia?
That's the bradycardic rhythm. You can look at it.
Turmeric, dude, I gotta get turmeric.
At least 5 or 6. It's like, oh yeah, I need that.
All the radiols you done the other day. That's terrible. I was looking at Love Major Passion playing a dark blue. That is terrible. Yeah, at least it's like energetic stuff. Stop. Just probably good play.
I just fully charged my battery. That's like 3 hours.
You look at the one card like
Look, somebody text me out first thing out. You're unreal.
That was good, but yeah, like.
I like you guys tried harder being like I did it.
So what are you up to now? I'll give you another month here. You'll like come back.
I treated myself with that HEB. Every once in a while, I think I can piece it out.
I think we're like airport. How do you I don't want to. Maybe not.
They didn't move the test. We just added
I was good then.
Mine's a scratch.
It's happening.
Alrighty, so those were our primary bradyarrhythmias. Now we're gonna talk about some other arrhythmias that we might see. All the way down to bundle branch blocks, and bundle branch blocks, we actually have another lecture for that. But that is a type of arrhythmia that we might see. So sinus block. Sinus block indicates that the SA node is not completely healthy. It could be, again, usually from some sort of underlying myocardial disease, maybe a prior MI, or coronary artery disease, something like that. And what we'll see is just a complete block all the way from the SA node down to the ventricle. So we're missing the P wave, we're missing PR segment, PR interval, we're missing the QRS complex. So the entire complex, cardiac complex is missing. And then the SA node resumes pacing. And most of the time it's the SA node. It might be a different portion of the heart, and we call that an escape rhythm, some another rhythm escaped after that. But for here, we're just missing one entire cardiac cycle, P all the way to RT. Here we've got our PQRST, PQRST. If we were to march this out, and we would think somewhere in about here, we should have another cardiac cycle, but we don't. We missed one, and then we resumed pacing again. Again, sometimes it's the SA node that resumes pacing. Sometimes it might be from the junctional area, atrial area, ventricular area. But if you march these out, then you'll see like right in here, we got a missed cardiac cycle. And then marching this out, this picks up the pace of the pacemaker responsibility in that same realm where we take a piece of paper and we put it on this R wave to this R wave. We move it over here, we should have an R wave here, we should have this R wave here, this R wave here. So we march it out throughout, we just know that we're missing one complete cycle here. We look here, we've got our PQRST. It seems like we have a long way between this R wave and this R wave. We could think of this as an escape beat, just an escape rhythm, right? We come in here. So sometimes that's the case, but if we were to march this out, we should have an R here, and then this R line. Escape it's just a little bit later than normal. It's not a complete cycle, it's a cycle, and then a little bit later after that cycle. But here, when you march these out for a sinus block, it marches out right on point. Here, you should have an R wave here, and then your R wave here marches right out. If this was an escape rhythm only, we would have our cycle here that's missed, and then your escape rhythm is going to start right after that, not march out in alignment like we have here. Okay, so we march all these out. Here we should have a QRS complex here. We didn't. But then the body recognized that, picked it back up, right in alignment, started beating again. It's not just a little bit late, it's an entire cycle late, and then we don't have, for escape, it would be right after this cycle is missed. this is an entire cycle, and then we resume when it's supposed to in the next cycle. That's a sinus block. Sinus arrest, we're missing 2 or more cycles, 2 or more complete cardiac cycles. So you've got our PQRST, our waves are marching out, but for some reason we're missing a cycle here. We can look and see, okay, this is irregular. What is going on? Once we identify that it's irregular, we've got to figure out what the reason is. So for this, we should have a cardiac cycle here. We should have a cardiac cycle here. So we're missing 2. We don't. But then this next cardiac cycle comes right in rhythm like it's supposed to. So we're missing 1. We're missing 2. It's not just a little bit late, but it comes right in the next cardiac cycle. So it'll march out, but we're missing this middle piece. And that's how you know this is a sinus block, 1 cardiac cycle versus sinus arrest, 2 cardiac cycles versus just an escape beat. An escape beat or escape rhythm is occurring just after where that cardiac cycle would occur. So just after that cardiac cycle, not a complete, it's not falling in rhythm. It's just a little later than it should occur. This is an example of a sinus arrest. We've got our R to R here, R to R here, here. We're missing an R to R here. We're missing a QRS complex here. We're missing a QRS complex here. And then this falls right into patterns. If you marched all of this out with your piece of paper, okay, so if we took this piece of paper and we marched this out, and again, it's hard because it's on my paper right there. So we've got it here, and we've got it here. We can march it back and march it right up. So what I see here on march, I should have a QRS complex here. I should have a QRS complex here. And guess what? This lines exactly up with those marks. Okay, so it tells you you're missing 2 or more cardiac cycles, which is a sinus arrest. Sinus block is 1 cardiac cycle. If we look at this ECG, this rhythm strip at the bottom, okay, do we think this is a missing 1 cardiac cycle, like a sinus block? Yes, sir.
I was curious, will these patients be like symptomatic, at least with the sinus block, or are you considered?
Most of the time depends, so not necessarily the sinus block. They might be, they feel like their heart is, like it's skipping beats or something. Okay, they may say that. With a sinus arrest, depends on how many it skips, right? So if you skip 2 or 3 in a row, you're gonna probably be start to be symptomatic. And you're gonna feel like your heart, that's what they come in, like I feel like my heart is skipping a beat, and then it starts back up again. What do we think this is, sinus block or sinus arrest? Sinus block, right? So we don't have much information here, but if we go backwards and we march R to R, R to R, it really looks like we're missing a complete cardiac cycle right here. Okay, but then the next cardiac cycle goes right into alignment with where it should. It's not just a little late like a escape beat, it goes right into cardiac cycle. That's a sinus block. The problem with sinus blocks and sinus arrests, okay, they can be associated with something called sick sinus syndrome, also called Tachy-Brady syndrome. And Tachy-Brady syndrome, you will have really fast heart rate, really slow heart rate, so sinus tach, sinus bradycardia, or SVT, sinus bradycardia. You have periods of sinus block, you have periods of sinus arrest. These patients are just wanting to die in front of you. Okay? They're just wanting, they're willing themselves. So if you have someone that has this, they will be symptomatic. They probably syncopized, which is what caused them to come in. The problem with sick sinus syndrome, so I've seen sick sinus syndrome twice ever in my entire medical career. And both of them were in the ICU for a syncopal episode. Their evaluation in the emergency department was unremarkable. We happened to walk in, and on their monitor, they were going in and out of this rhythm, this tachyrhythm, Brady, and then they had these long pauses, so these long sinus arrests. So this entire time period, they're not having any cardiac movement. There's no depolarization, which means that the ventricles aren't depolarizing. They're also not pushing out blood to the rest of the body. So these patients will be symptomatic, and their treatment for this is a pacemaker. So this is actually one long rhythm strip. I put it on 3 here, but if you took this and cut it into 3 sections, it's one long giant rhythm strip where they go from what appears to be kind of, a little bit fast, okay? 300, 150, then we got a pause here, and then kind of fast here, and then this long pause. Then we come down here, it gets a little bit where the rate is a little bit slower, and then back to faster and then slower. So intermittent, fast, slow with these long pauses. Looks like, if you just walked in and the only thing you saw was this, looked like a flat line, right? Like someone had cardiac arrest. And you're just like, oh my God, okay, but the patient's talking to you. But they're feeling lightheaded, they're probably feeling dizzy. There's something with the SA node. The SA node is about ready to give out completely, and the rest of the heart is soon to follow with that. Sinus arrhythmia. Sinus arrhythmia is a normal variant. Normal variant. And what you'll see on that bottom rhythm strip is you'll see slight irregularity. It's not like totally obvious, but you'll definitely like, oh, that looks a little bit longer and a little bit closer. Okay, so you'll see some slight irregularity in that bottom rhythm strip. You look up at lead 2. Lead 2 P is upright, AVR is down going, so it looks like it's coming from the SA node. But the real issue is really, when you look at this, it coincides with the patient's inspiration and expiration. So in inspiration, we have a slight increase in heart rate for some people that have a really sensitive sympathetic and parasympathetic system. Okay? And in expiration, we have a slight decrease in our heart rate. So you'll notice on your EKG, you've got your PQRST, PQST. The next one's a little bit closer, okay? And then the next one after that was a little bit further away. We have an increase in vagal tone, decrease in vagal tone, or increase in heart rate a little bit, and decrease in heart rate a little bit, all in relation to respiration. So what's going to happen is you'll notice that, and just watch the patient. Put your hand on their pulse, watch the patient's respiration. You can actually feel it increase a little bit and decrease a little bit while you're watching their respiration. It's like, oh, that's totally coincides with their respiratory rate. Or their inspiration, expiration, not really the respiratory rate, their inspiration, expiration. And on EKG, you can see that. You don't see it very often. Again, people that have pretty sensitive sympathetic and parasympathetic systems, you'll see it more often. But it's a normal variant, totally nothing to do with it, and the patients have no idea. They have no idea that that's even going on. You only see it on ECG, or sometimes if you're checking their pulse, you can feel it on their pulse as well. And that might prompt you to get an ECG, and then you can see it on ECG. If we were to look at this bottom rhythm strip, and we were to march out these R to Rs, can everybody see between this R and this R, we have a slight delay where it doesn't seem, where if we march this out, we think that the R wave really should be about here. So this is taking a little bit longer, but we know we have a P, we have a QRS, we have a T associated with that, and then it looks like it's back to normal, okay? So that's what I'm talking about. It's just a slight delay, okay? And then you might have a slight, where it comes a little bit early, a little tiny bit, maybe a half a box or so, maybe one small box. And it's all in association. So I can see their respiration. It's totally in association with their inspiration and their expiration. Nothing to do. Normal variant. Wandering atrial. If I told you this rhythm, you have 3 or more different morphology P waves. 3 or more different morphology P waves. What does that coincide with? MAT. The only difference is this is MAT not on steroids. This is MAT more on maybe cocaine. Maybe cocaine. I hope not cocaine. But this is MAT on maybe marijuana. Slowing you down, slowing you down. So wandering atrial pacemaker, 3 or more different morphology P waves, but rate is less than 100. Still the same underlying causes, which is respiratory or pulmonary causes, but your rate is going to be less than 100. So make sure when you're reading the stem and you're looking at that ECG, if you have a rate that's greater than 100, 3 or more different morphology P waves, MAT. less than 100, 3 or more different morphology P waves, wandering atrial pacemaker. But the underlying etiology is still going to be the same, some sort of COPD, some sort of hypoxemia, or hypoxia is due to something issue, some pulmonary issue. Oftentimes, they don't know that they have these 3 different morphologies. They're not having symptoms associated with the EKG changes. They're having symptoms associated with the underlying etiology of the EKG changes. The treatment for this is to fix the underlying etiology. This is wandering atrial pacemaker. Our heart rate here, if we count all these out, is about 96. But we can see we've got different morphology P waves. This was a pretty normal appearing P wave, kind of a flat appearing P wave here, flat here. This is inverted here. Okay, so 3 or more different morphology P waves in this setting, especially in the setting of pulmonary disease. We talked about ectopic rhythms, okay, escape rhythms. Escape rhythms are occurring a little bit later. Okay, we also want to talk about premature beats. Okay, premature. So premature means it occurs earlier than we expected. If we have an escape, it's occurring later than what we expect. Premature beats can be premature atrial beats, or premature atrial contractions, premature junctional beats, or premature junctional contractions. You're going to use those words interchangeably, and then premature ventricular beats, or premature ventricular contractions. So again, it is occurring earlier than we expect. If you measure out your R to R, remember R to R helps us with our rate, but it also helps us with our rhythm. R to R, we measure it out. The next R is occurring earlier than what we would expect it to occur. So we mark this out here. We expect the next R to be way over here, but it's actually earlier. It's a premature contraction, premature beat. And the cause of this can be many. But something is occurring that we're having initially a normal depolarization from the SA node, but then there's a foci either in the atria, the junction of the ventricles that is depolarizing earlier, and depolarizing, taking over that pacemaker responsibility just for a beat, okay, for some reason. It's irritable for some reason. Maybe it has to do with that increased sympathetic system. Maybe it's from medications that these patients are on. Maybe it's from thyroid problems, or even anxiety can cause this to occur. A lot of energy drinks can cause this to occur as well. It can be the premature atrial contraction. So with a premature atrial contraction, we're going to have our normal R to R initially, but then the next beat, a beat or 2 in, it's going to occur earlier than normal. So R to R here looks normal, R to R here looks normal, but this next beat is occurring earlier. And we know it's coming from the atria because it has an associated P wave. But that P wave is going to look different than the other P waves. It's coming from a different foci. It's not coming from the SA node. If we look here, we've got an R to R here, okay? And then we have this beat here that looks a little bit early. Now, some of you might not be able to see that, so it's no big deal if you come back this way with this little rhythm strip that we have. Say, okay, that R to R looks normal, R to R, R to R, but then something's happening between these 2 beats. And really what it is this beat here is occurring a little bit earlier than what we would expect. So premature. Here's a couple more instances of premature atrial contractions. R to R normal, if you measure it out. This is occurring earlier than normal, and look at the morphology of that P wave. It's much more peaked than we can see the morphology here. So that morphology of that P wave is more peaked. It's coming from a different foci in the atria, and it's occurring earlier. It's called taking over pacemaker responsibility for that beat. And then after that, the SA node has resumed firing. We've got back to our normal PQRST. We got another example here. We look at this P wave and this P wave. We are looking at our rhythm. It says, look at the P waves. Do all P waves look the same? They should look the same. And if they don't look the same, now we have to figure out the rationale. Why don't I have that? If you look at that P and you have an associated QRS complex, are those QRS complexes marching out? For this one, it's occurring earlier we march back here, march this out, it's occurring earlier here, and it has an abnormal P wave associated with it. No, it's an atrial beat because it has a P wave. When we talked previously about junctional, we talked about ectopic junctional rhythm where it's occurring later, and then we have junctional areas taken over. Well, it's no different than we talked about for junctional escape rhythm. The only difference is this is a premature beat that's occurring earlier. But what do we expect with that QRS complex? Do we expect that we're going to have a P wave or no P wave? No P wave. If we do have a P wave, how might that P wave present? Upside down, inverted. It's the same exact thing. So not only do you want to think about junctional premature or later, happening later, but also put lights with like my atrial. If I have an atrial focus, okay, I'm going to have a P wave with it. If I have a junctional focus, still going to be narrow, but I'm not going to have a P, or that P wave is going to be inverted. If I have a ventricular focus, it's going to be what? Wide, no P wave. Wide, or at least not a visible P wave. P wave can be within there. So here we have a premature contraction that's occurring. We go R to R, R to R, but this is occurring earlier, and we don't have a P wave that's associated with this, the premature junctional contraction. Up here we have R to R, R to R looks normal. We've got our P, we've got our P. Look here, we have a premature contraction, and this is our S comes up, this is actually our T wave, but this contraction is occurring right after our T wave, so no P wave with that. This bottom rhythm strip, this 10-second rhythm strip. Okay, again, I do see we have very low voltage QRSs, but in between those low voltage QRS, if we march this out, this from here, okay, we would expect if we're marching this out, we should have something, okay, just right at the end of here. But this is occurring a little bit earlier. It's narrow. We don't have a P wave here. Same thing here. We don't have a P wave. We don't have a P wave. So this patient is having pretty frequent premature junctional contractions. Very narrow QRS and no associated P wave. That leads us to the ventricles. Ventricles. So we can have the SA node that fires, but there's some foci in the ventricles that takes over the pacemaking responsibility for one beat. Okay, sometimes it's more than one beat. You can have two premature junctional contractions in a row. You can have two premature ventricular contractions in a row. Okay, but what you're going to see for the ventricles is that wide in-your-face QRS. It just looks like it hurts. And these patients often will come in complaining of they feel like their heartbeat is really hard. Their heartbeat is beating really hard. And they feel like their heartbeat is beating in their throat because the ventricles are beating earlier than normal, and it's a pretty significant heartbeat that they're having. So wide, no QRS. Wide, no QRS, and it's occurring earlier, so premature ventricular contraction. You're going to see premature ventricular contractions all the time. We don't see that many premature junctional contractions. Ventricular contractions all the time. Patients are going to come in all the time with this, and you're going to see them on ECG. Oftentimes, you just got to figure out what does their diet entail. Are they using a lot of caffeine? There's not really any specific thing to do for it unless they're having a lot of these, and then we might have to intervene. On ECG, it's going to look like this, where it looks like a fairly normal, but even when you take your eyes and you look at that bottom rhythm strip, one thing that should really stick out from the very beginning is like, whoa, what is that thing? That's a PVC. That's a whoa, what is that thing? It's like, oh my gosh, I don't want that because it looks like it hurts. That's a premature ventricular contraction, a heartbeat that's occurring earlier than normal, and big and wide because it's coming from the ventricles. If you have really bad irritation in the ventricles, we might have these runs of PVCs. What do those runs of PVCs look like? They look like VTAC. If we pull up a picture of VTAC, that's what it looks like. Okay, 3 or more PVCs is technically considered ventricular tachycardia. Okay, what we hope is that the patient goes out of those PVCs and goes back into a regular normal sinus rhythm. Okay, so if you do have 3 or more, now we have to determine is it lasting less than 30 seconds or greater than 30 seconds. Cardiology really only cares if it's sustained VTAC and non-sustained VTAC. I'm gonna be honest with you, as primary care, we care about both of them, right? So in the emergency department, but in primary care, if I saw someone come in and they had this on their ECG, I'm calling somebody. I'm not gonna let them go home because I don't know what this is gonna turn into, right? So it is important for you to understand that PVCs, when you get them occasionally, it's usually not that big of a deal. If you get runs of PVCs, something is causing some pretty significant vocal irritation in the ventricles. Okay? And we probably need to address that sooner than later. Bigeminy and trigeminy. Again, one of those things that probably not that big of a deal, but what you'll see is when we think about QRS, we looked at QRS complexes. Are they there? Are they regularly spaced? Are they grouped? Okay, this is the grouped QRS complexes. So you'll have a normal QRS complex, and then you'll have a premature beat right after that for bigeminy. Normal, and then premature. Normal, and then premature. For trigeminy, you have a normal, okay, or you have 2 normals. You have a normal here, and you have a normal here, and then you have a premature beat that couples on top of that second normal. A normal, and a beat that couples on top of that. Patients are running frequent bigeminy or trigeminy. They also need to be evaluated. It isn't necessarily an emergent call to the cardiologist, but it's definitely a cardiology consult, and also going through their daily history of what their intake is to figure out what's the underlying cause. Because it's not normal to have consistent bigeminy and trigeminy. Okay, and these patients usually will feel like their heart is skipping a beat or not beating quite right. And that's what you'll see is this coupling of these premature beats on top of normal beats. You can see it with junctional as well. We don't really typically see. So if we're thinking about with the ventricular premature, it's usually going to look like this. But we can see with junctional, where you have junctional bigeminy or junctional trigeminy. 2 normal, and then you have junctional. And the only difference is you're not going to see that P wave that's associated with that. Premature beats, escape beats. Premature rhythms can occur, escape rhythms can occur. So just like we talk with premature beats, we can have premature atrial escape beats, junctional escape beats, and ventricular escape beats. They're going to look just like a premature, only they're occurring later. So an atrial escape beat occurs later. Okay, here it occurs later for junctional, no P. For PVC, for escape, ventricular escape beat is occurring later with no P wave. No P wave, this is occurring later with a P wave. And how do you determine between an escape beat or escape rhythm? Well, the book answer is an escape rhythm is 3 or more escape beats. So if you're looking and you've got 3 or more escape beats, then that is technically considered an escape rhythm. Even if it goes back to a normal sinus rhythm after that, that still is considered that you had an escape rhythm that then ultimately went to a normal sinus rhythm. An escape beat is going to be 1 or 2 beats in a row. Rhythm is going to be 3 or more beats. If we compare escape beat versus premature contraction, escape is going to occur after it normally would have. So you got to march out those R to Rs. If your R to R is not marching out, well, is that next R occurring earlier, or is that next R occurring later? If it's occurring earlier, it's going to be a premature contraction, and then you've got to figure out, is it premature atrial with a P wave that looks different? Is it junctional with no P wave or an inverted P wave? Or is it ventricular with that wide QRS complex? Okay, same thing with our escape. It's occurring later than that R wave should have occurred. So you're going to march out your R to R. This one's not in the spot that it's supposed to be. Is it earlier or it's later? Is it atrial? Is it junctional? Or is it ventricular? So P wave or no P wave, wide or narrow. Wide is going to be your your ventricular beat. All right, that brings us to pre-excitation syndrome. There's two pre-excitation symptoms we talked about. WPW is going to be the most common, and then lone gain on Levine is going to be another pre-excitation. And both of these are associated with an accessory pathway. There's a superhighway that's allowing conduction to occur directly from the atria down to the ventricles. If you recall, in our tachyarrhythmias, we talked about this. We talked about this in association with something called AVRT. So AVRT is WPW tachycardic. So people are going to have WPW and have a non-tachycardic rate. Okay? But if it's tachycardia, if it's a tachycardic rate, okay, it's typically AVRT is what we're going to call it. So it's a form of SVT. And then there's specific things that we look at. Specifically, we look at for WPW. Okay, the lesion for WPW can be on the right side or the left side. So the accessory highway can be on the right side or the left side. And again, the AVRT is that combination typically of that WPW with the tachycardia. Lone gain on Levine, accessory pathway only. This accessory pathway is called the James bundle. And it's an internodal accessory pathway. It's going to actually bypass the AV node. So you've got depolarization that's coming around the AV node going directly down to the ventricles. And the problem with that is, remember, the responsibility of the AV node is to allow for that slight delay in depolarization between the atria and the ventricles. Well, some of the depolarizations are going that way, but others are going around the AV node. Same thing with WPW. Some of the depolarizations are going that way, but some are going around in that superhighway. So how are they going to appear, and what are they on EKG, and also a little bit what is the underlying pathophys? So we realize that from the normal SA node depolarization occurs, we have depolarization that goes from the SA node down to the AV node, and then from the AV node down to the ventricles. Well, that is still occurring, but some of those depolarizations are also going down through that accessory pathway, whether it be on the right or on the left. So we've got depolarization going here, and we've got depolarization coming down here. When that happens, we now have an issue. And the issue is that our ventricles are no longer depolarizing at the exact same rate. Which means what part of our EKG complex is going to be affected? The QRS complex. So you have the R wave. Our QRS complex is going to be affected, primarily the R wave. Great. Now, some of these depolarizations are bypassing the AV node. What other part of our EKG complex is going to be affected? If we're bypassing part of it, it's bypassing the AV node. PR interval, that PR segment is going to be affected as well. So those are the two main areas that we're going to identify as abnormal on our EKG. And because we are having depolarization of the right ventricle and the left ventricle, depending on where that accessory highway is located, at different rates, our main area that we're going to see that in is we're going to see it in our upstroke or upswing of our R wave. So our PR interval is going to be shorter than normal because we've got depolarization in the ventricles that is occurring earlier than what we'd expect. And even though some of those depolarizations are going through the AV node, we've got depolarization of those ventricles earlier. And because they're depolarizing at slightly different rates, instead of going straight up and straight down, okay, we've got this kind of either convex area, or concave. It can be convex, but more often concave of our R wave. Instead of straight up, straight down, it's more concave. Or it can even look a little squiggly as those depolarizations are occurring. What we don't see on this is we don't see that straight up and straight down. This area that we're seeing, this concavity, or this kind of squiggly, is called our delta wave. And delta wave is specifically associated with WPW. So you're looking for a PR segment that's shorter because we're having depolarization of one ventricle a little bit earlier than the other ventricle. Okay, we're bypassing that AV node for some of those depolarization. And then the upswing of that R wave is gonna look weird. It's not gonna be straight up, straight down. It's gonna look like it kind of comes in a little bit or kind of squiggly a little bit. But oftentimes, what your first indication is, you're looking, because sometimes that change in that upstroke of the R wave, sometimes it's a little bit difficult to see. Your first indication is, why do I have a short PR interval? What's going on? That's gonna be your differential. For a short PR interval, should be WPW, lone ganglion, the electrolyte derangements can cause that as well. So it can be type A or type B. Type A, on type A, the accessory highway is located on the left side of the heart, okay, between the left atria and left ventricles. And then type B is the right-sided pathway, right side of the heart. Both of these are going to have a short PR interval. Whether it's on the right or the left, they're going to have a short PR interval. Both of them are going to have a delta wave. Okay? And that's what's really, 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 really important for you guys to know. Okay? The other part is, how do we determine if this is left-sided versus right-sided? If you recall, the normal R wave progression in the precordial leads is that we have a very small R wave in V1 and V2, and progressively the R wave gets higher and higher amplitude as it gets down to V5 and V6. Well, in a left-sided pathway, that is reversed. We have a very prominent R wave in V1 and V2. The other thing that we've talked about is a T wave. We've talked about the T wave, and we have said that that T wave often follows the QRS complex, and whether that QRS complex is more positive versus more negative. If the QRS complex is more positive, meaning your R wave is above your baseline, higher than your S wave goes below baseline, more positive, then our T wave is typically upright. If your S wave is deeper than your R wave is positive, then it's okay for your T wave to be inverted. It goes with the QRS complex. But for this, for the type A, the left-sided pathway, we have a prominent R wave, and we have inverted T waves. So V1 typically has a small R wave, okay, and a big, deep S wave, and inverted T's. That's not unusual. But here we have a prominent R wave with inverted. Does that R wave not, or that T wave is not following in path with our QRS complex? That's how we know it's a type A left-sided, because prominent R wave has got these inversions here. Okay, for our type B, our right-sided pathway, look at our R wave. Is that normal? Is that normal for us to have a little R wave in V1 and a deep S wave? That's normal, right? Okay, we would expect a very small R wave here. R wave here gets bigger, and then we have a larger R wave here with hardly any S wave. So we expect that. So we have a normal R wave progression, but what we have here, we have that T wave inversion. So that's going to be, truth be told, I don't care if you know between type A and type B. I don't care. Okay? What I do care is you've got to be able to pick out a delta wave. So let me show you a little bit better picture of a delta wave here. This, when you look up close, this is what a delta wave looks like. If you see on that EKG, okay, there is a shortened PR interval. This has to be under differential. People will die if you miss WPW. Okay? So it's really, really important. A lot of these patients they'll end up going to the cardiologist for an ablation, and some of them will need a pacemaker put in. A lot of times they can manage them via an ablation, right? Because they'll do something with that accessory pathway. But both of these are a short PR. Both of them are going to have a widened QRS complex, okay? And then we're gonna look for that delta wave. That upslope of the R wave is gonna be either concave, okay, typically, or you might see a little squiggle. So look close. On the exam, okay, I will allow you to bring things closer to your eyeball. Some of y'all got little tiny screens. It's okay to zoom in. Okay, it's not okay to go to another tab. It's okay to zoom in to be able to see this. All right. Now, so this again is a picture and another lead of that delta wave. You can see how it might be difficult to see this delta wave. And in real life, it is also difficult. So I want you to at least be able to look and say, hey, I've got a short PR interval. And if I've got a short PR interval, there's a problem. And my number one is going to be WPW, and my number two is going to be Longain-on-Levine. And I'm going to get some electrolytes on these patients as well. So Longain-on-Levine is an accessory pathway around or off the internodal tracts. It goes around the AV node. So we've got firing at the SA node, but that firing is going to come down, and some of it's going to go down to the AV node and down onto the ventricles, but then some other depolarizations are going to go around the AV node, this James bundle, or bundle of James, and it's going to go directly down to the bundle of His and down to the ventricle. So how this might present then is, remember, then we're having bypassing that AV node, so that's still going to affect the PR segment. Okay, the other thing that we have for this is we do not have a delta wave. We do not have a delta wave. So short PR interval, yes. Okay. Why am I confused? Short PR interval, yes. We do not have wide QRS. The ventricles are still depolarizing the same. It's just bypassing that AV node. So we have a short PR interval, a narrow QRS, and no delta wave. So the only indication for this is going to be somebody that probably otherwise healthy, had a syncopal episode. Both of these typically affect young folks, so adolescents up into the mid-30s or so. Okay, and oftentimes they will have syncopized or felt like they were going to pass out. So they passed out or felt like they were going to pass out, and that's what prompted them to come in. You do the ECG, you notice a short PR. As soon as you notice that short PR, your eye should go up to that R wave. Is it concave? Is it kind of squiggly? Is it wide? QRS complex. Right? And that is it for today. We'll finish this up tomorrow.
I don't know.